So Dr. Kumar Saurabh is a senior VR specialist at BBI Foundation, Trenetralaya, Shankar Jyoti and Apollo Clinic. So if we look at our first case, this is a diabetic retinopathy. So plan is to inject Razumab in the right eye. She has already undergone multiple injections in the right eye as well as a focal laser over the last 3 years. We look at the OCT. I am no retina specialist, but I can see some CSME with hard exudates there. So in spite of multiple injection, it is non-resolving.
So Dr. Saurabh is going to give the injection Accentrix in case of diabetic macular edema. So
Dr. Surinder,
yeah.
this is Dr. Saurabh from the.
Oh, good morning. Good afternoon, sir.
Good afternoon. We've been giving injections in the OT, all of us.
Okay, sir.
But there are few people, I know L.V. Prasad specifically, and a few of us have started giving the OPD. And
Sir,
I think the recommended is also in the OPD with only poverty and iodine. I'll ask Dr. Prashant Navamkule, in Nagpur, are you giving still in the OT or in the OPD injections, intravitreals? OT. Sir, still in the OT. Any reason why you still want to give the OT? We all give it the OT, just to clarify.
Sir, sorry, sir. Please speak loudly.
Okay. I speak very loudly.
Yeah, the question was whether we should give intravitreal injections inside the OT, or some of the people now propagate that it should be done are the proponents of giving it in as a OPD procedure.
But I would suggest to go for, and give the injection in the OT.
Yeah.
Better
Most
to
of
in the
us,
sterile environment.
everyone does so in our country,
Yes, sir.
majority, except for one or two people. I think Srinivas Joshi at Hubli, he believes giving, and I have seen him giving in OPD itself.
OPD.
They have an injection room, what they call.
Okay, sir.
But for me, I would still prefer, I treat even an injection as a simple, complete surgery. We drape ourselves, we wash for every injections, we change our gowns, we change the clothings and everything, draping and everything. So for us, it's like any other simple intraocular surgery.
So we are still giving in the OT, sir.
That's the way.
No,
Yes,
that
sir.
is what I wanted the whole other audience also take home message was, even though it's given very commonly nowadays, one shouldn't take it very lightly and give it as the due importance that it should get. बहुत आसान है, 2 minute में हो जाएगा is okay. It's like how they say phaco surgery also. I keep saying no.
Yes,
It's
sir.
not a 2-minute surgery. A phaco is an extremely important surgery, and
Okay.
it's been trivialized about. That's same with our injections also. My next question is regarding what I would feel is when one is giving injection to
Yes.
stabilize the eye with the cotton tip applicator rather than pushing the needle directly to the eye. The patient feels a little comfortable if you hold the eye steady with the cotton tip applicator. I think that's Prashant, when you give the injection, do you push the needle directly or do you hold with the applicator?
No. For us, naturally, it depends upon the patient to patient. So it's always preferable and prudent enough to stabilize with Johnson Bud one applicator. Basically, because you don't know this particular patient would suddenly move his eyes and then you will injure the lens or the retina.
I have a question for Sinha, sir. That when do you plan for the Ojudex or even IVTF along with the Accentrix or Razumab?
I do not practice that at all. I do not believe in double injections.
Because many people do this for the PDR with CSME.
Yeah.
In that case.
No, I think we should be very clear what we're treating. I have no opinion on that.
Okay.
I personally don't do it myself.
Okay.
I would prefer an anti-VEGF first.
Okay.
In a PDR with CSME. Wait for 3 weeks, repeat the OCT, and then start the laser.
Okay, sir.
And again, depending on fakie, how the other condition is different, Ozurdex next time. But my first choice would be the anti-VEGF in PDR with CSM.
Okay, sir. Okay.
Yeah, we need to understand why do we need to combine? Is there really a need to combine? The cascade along which the anti-VEGF or a steroid works is almost similar except for the first two steps.
Mhm.
And when you are going for a primary injection, see, I don't see reason why you should there is a need to combine, frankly speaking. Either you opt for a steroid, if it is a pseudo phakic eye, you have a more degenerative type of a seeds, you have lot many HRDs. In that cases, well, either go for it or have your own conviction
Okay,
for
sir.
the mechanism of action, why it is happening, rather than putting it like a, shooting it in the dark star. Aim it and shoot it.
Okay, sir. Okay.
If we can change the topic a little bit, this is something I am a little aggressive about.
Yes, sir.
A lot of our anti-segment colleagues want to or sometimes partially give anti-VEGF injections. And my request to all of them is that if you can think of that or are doing that, then when you have a suspected endophthalmitis, give the antibiotics endophthalmitis also, Intravitreal also. It's not just the anti-VEGF.
So I can speak on either side, but yes, understanding the indication rather than shooting at the stars is more important. Learn the retina and then do it, then have the prudency, not just because someone did it, one of the VR surgeons came to your OT and you saw that it is easier to inject. Well, you see on a OCT some thickening and it is there. See, OCT thickenings can happen, macular thickenings happen because of n number of reasons. That is the most important thing. So if you know how to interpret it, then you should.